I also noticed over there where she's speaking, at the bottom, that microphone also is muted. You might try to. What happened? Okay, click where it says DC Council, that mic is muted, unmuted, unmuted. Try to click on it. Well, there to your left, right up on where she's speaking, there's a little microphone that says DC Council. It's muted to the left. Right up on where she's speaking. Yeah, try to unmute that. The little red microphone is real small over there. Try to unmute it. I think so. You see the little microphone where it says DC Council? Right up under the picture where she's sleeping. This little red microphone that's muted, that's next to it's a live video. So you to try and unmute it. Well, maybe they're controlling. I believe they're waiting for me to speak. There is nothing that I can control. It's muted. I think they're controlling. And if you click on the little thing down there that says chat, you can always type in a question or whatever to see it. Okay, now you get them. Right. I heard that's on TV, but I have not heard anything of them now.
Anyone's here, we're just trying to work out some technical difficulties that we seem to be having. Mr. Gardner, do you mind unmuting and saying something if you could hear me?
Yes, good morning.
Good morning.
Yeah.
Okay, just thank you. Give us just a minute.
Okay.
Okay. Apologies. Thank you for bearing with us on that. Ms. Yasmina Castellanos, you're first.
Yes, good morning to everyone.
Good morning.
Yes, good morning, council. Good morning, colleagues, partners. Thank you for this opportunity to be present and to be able to provide testimony on how DC HealthLink, the program that allows for our DC residents to be able to enroll in insurance, have a voice. Despite the limitations that we have experienced with the pandemic, our DC HealthLink program and enrollment assisters have continued to support enrollment and outreach efforts throughout the whole year. And this ensures that our DC residents are educated, enroll, and are covered. Our partnership with DC HealthLink has allowed us to support the community while we also provide healthcare. So we're partnered with the exchange program, and it's a great combination. We have 3 clinics across the city in different quadrants, northeast, northwest, and southwest, in wards 1, 5, and 8. And we're proud to say that we have remained very active at the forefront of everything that we have faced. And we've been providing healthcare while also ensuring to connect with neighbors, friends, and small businesses. And with especially the current open enrollments period that we've have lived, we have been able to assist many residents who have been paying high premiums now, being able to educate them with the help of the DC HealthLink program. We were able to provide more information on assistance to get covered. We have also not just assisted residents eligible for some of the private plans, but we've also have assisted many eligible residents for the DC Alliance program, the Medicaid program, and including our elderly Medicare population. This has allowed us the opportunity to emphasize the importance of visiting their doctors and having insurance. And we're such a vital presence or source in the community. And we ask that you continue to fund DC Health Exchange's DC HealthLink program for the greater good of our residents' overall health. Alone in 2022, our partnership with DC HealthLink has allowed us to service over 4,000 residents. And we've touched over 7,300 families. So we're just one entity. Imagine the impact that all of the other partners can do across the city for all of our residents. So we thank you for this opportunity, and we hope that you're able to continue funding the DC HealthLink program. Thank you very much.
Thank you. Mr. Gardner.
Good morning, Chairwoman Henderson, members of the committee. Thank you for the opportunity to testify today. My name is Chris Gardner. I'm the founder and president of GKAPC, a certified public accounting and management consulting firm here in the District of Columbia. I'm a former treasurer of the boards of DC General Hospital and Howard University Hospital. I was the vice chair of the board of United Medical Center for 5 years and chair of the board for 2 years. I am currently the chair of the DC Health Benefit Exchange Standing Advisory Board, and I have served in that capacity since the creation of the advisory board. I testified today in that capacity to support the work of the exchange and to urge the council's continued support. The advisory board was established to provide recommendations to the executive board on any policy or operational issue within the executive board's discretion and direction. It is comprised of district residents with relevant healthcare expertise. It includes health professionals, health insurance brokers, health plan representatives, advocacy groups, and customers of DC HealthLink. DC HealthLink continues to be recognized as a national leader among the nation's exchange marketplaces. In that regard, when Congress passed and President Biden signed into law the American Rescue Plan Act in March 2022, DC HealthLink made premiums as low as $2 per month available to DC residents within 2 weeks. DC HealthLink quickly began compiling facts and testimonials about the impact of low premiums and to push for their permanent extension. This effort culminated in the passage of the Inflation Reduction Act in March of 2022, which extended the lower premiums through 2025. And Director Kaufman and her team are working to make that extension permanent. As a national leader, the exchange has worked to advance health equity through DC HealthLink standard plans. These plans add value to individuals by having no deductibles for primary care visits, specialty visits, urgent care, and generic prescription drugs. They are now also being offered for the first time to small businesses. The Exchange Small Business Health Options Program, known as SHOP, is one of the strongest in the country. It has grown since last year with nearly 3,000 more people covered. The exchange offers 211 plans with 54 new plans this year. 5 plans have lower premiums in 2023 than in 2022. There are 4 health insurance carriers, and uniquely, the exchange offers employee choice. This allows small employers to offer their employees a choice of plans just as many large employers do. 69% of employers do so. Consequently, it is important that DC HealthLink is at the forefront of support tools that help customers identify the right plan for them. DC HealthLink's tools can help the customer quickly identify which health plan meet their needs. DC HealthLink also partners with brokers through training and certification to help provide individualized service to DC residents and employers. The exchange process of seeking input from stakeholders, working toward consensus recommendations, and developing partnerships with trusted community voices has created a top-notch marketplace with competitive choices, a streamlined, easy-to-use application, and strong customer service, including one-on-one enrollment assistance. Director Kaufman and her team should be commended for its success. I am proud to serve on the advisory board, and I appreciate the opportunity to testify today. Thank you very much.
Thank you. We'll now hear from Lindy Campbell from Music on the Hill.
Can you hear me?
Yes, we can.
Okay, great. Good morning, Chairman Henderson and members of the Committee on Health. My name is Lindy Campbell, and I'm the owner of Music on the Hill. I'm pleased to offer testimony before you today regarding DC HealthLink and the positive impact it has had on our small business. I also want to highlight the extraordinary care that DC HealthLink's small business team took during the COVID-19 pandemic to find solutions for all of our employees and their families to have access to health insurance customers. We are a retail music store, music education center located in Capitol Hill neighborhood. We have been DC HealthLink customers since 2018. We offer our employees coverage at all metal levels through the CareFirst Blue Cross Blue Shield. This way they have the ability to choose the plan that best fits their needs. Like many DC small businesses, we had to pivot and adapt to a new business model to survive the pandemic. We had been doing lessons in our store, group classes, private lessons. Those all moved online. We had to move them online in about 2 days, I think we had to do that, and we did it. We made it possible for all of our teachers to keep their jobs and to teach from home. But we needed a team who was passionate about music and loves teaching for our small business to survive. Offering quality, affordable health insurance coverage to our full-time employees has always been a smart business decision. Any small business owner will tell you that attracting good employees can be difficult. Being able to offer benefits through DC HealthLink with the savings we see has made us more competitive and has helped us retain staff. In March 2020, not all of our music teachers were full-time employees. So right after the pandemic began, we worked with DC HealthLink's small business team to find coverage options for them. What worked for us was to convert some independent contractors to full-time employees, making it possible for them to have access to the quality health insurance coverage that DC provides. Even better, DC HealthLink made it possible for this new coverage to start right away. Knowing that all of my teachers had medical coverage felt really good, especially during the medical pandemic. I was very proud that by April 2020, 100% of my teachers and employees were fully covered with medical insurance. Music on the Hill received incredible community support during the pandemic. In fact, we picked up new customers, people returning to music after a long break, and musical novices looking to learn an instrument for the first time. We couldn't have done it without the outpouring of support from the community and our dedicated team at Music on the Hill. Thank you to DC HealthLink for working with us to make sure our team was taken care of with access to quality insurance coverage. Thank you very much for the opportunity to share my experience. I would be very happy to answer any questions.
Thank you. I don't see Elena Aaron, so we'll go to Christine Mahana
I'm here.
from Georgetown.
Hello. Can you hear me? This is
Oh,
Elena.
I'm so sorry. I do see you. I'm sorry, Elena. Yes. Go ahead, please go ahead.
I get it. I am not the technical queen in my house. So, good morning, Chairwoman Henderson, members of the committee. My name is Alana Aronin. I'm a senior policy associate in the Community Mental Health Core and Child Health Advocacy Institute at Children's National Hospital. Community Mental Health Core aims to improve access to and utilization of high quality behavioral health services for children and families, advance racial and health equity, and promote sustainability and system level change through research, policy, advocacy, and community engagement. As a provider of child and adolescent mental and behavioral health services in the district, Children's National Hospital was pleased to recently support DC Health Benefit Exchange in developing a low-cost benefits package for children's behavioral health services that reduces copays for outpatient services and prescription drugs. This effort aligns with our most recent community health needs assessment, which identified health insurance coverage as one of our 4 priority areas. Over the next 3 years, through our Community Health Improvement Plan, we will work to implement strategies that support the goal of improved access to healthcare and health insurance coverage. Children's National recognizes the increased behavioral health needs of children and adolescents and advocates for the continued support to help ensure that all children can access the full continuum of mental and behavioral health services. In support of this effort with the Health Benefit Exchange, Children's National identified the most prevalent behavioral health conditions for outpatient children and adolescents seen at Children's National Hospital, with a particular focus on those conditions that disproportionately impact Black and Brown children. Our multidisciplinary team then structured care models, which reflect best practices and can lead to improved access and well-being. These care models included all appropriate outpatient medical visits, therapy sessions, lab work, and appropriate prescription medications for those conditions. We recognize the high cost of services continues to be a major barrier in behavioral health care. In current standard plans, copays for therapy range from $25 to $45, making treatment inaccessible for many families when therapy is prescribed weekly or biweekly. The Standard Plans Working Group engaged in thoughtful and deliberate discussion, considering all the facets of this recommendation. The DC Health Benefit Exchange Board voted to accept a recommendation that all primary behavioral health conditions receive unlimited outpatient behavioral health services, related lab work, and medications on an approved list, all at $5 copays for children up through age 18 enrolled in Health Benefit Exchange Standard Plans. This is a significant cost-sharing reduction. We commend the DC Health Benefit Exchange Authority for its commitment and vision to health equity and improvement of behavioral health services for children in the district. Through their collaboration with a variety of stakeholders in developing a low-cost benefit package for children's behavioral health services, more children and families will have reduced copays for outpatient services and prescription drugs, which will result in improved access to care. Thank you for the opportunity to testify. I'm happy to answer any questions that you have.
Thanks, Alana. Apologies for missing you earlier. Christine?
Good morning. Can you hear me?
Yes, we can.
Great. Thank you for this opportunity to testify. My name is Christine Monahan. I work as an assistant research professor at the Center on Health Insurance Reforms, or SHEAR, within Georgetown University's McCourt School of Public Policy. SHEAR is an independent, nonpartisan policy and research center founded in 2011, where faculty and staff work to improve access to affordable and adequate health insurance by providing balanced, evidence-based research, analysis, and strategic advice. One of our longstanding projects, funded by the Commonwealth Fund, monitors and analyzes how all 50 states and the District of Columbia are implementing the Affordable Care Act's private insurance reforms and improving their health insurance marketplaces. As an expansion of this work, SHARE began monitoring health equity in 2021. For this part of the project, my team and I track state action to address disparities and inequities in healthcare and health coverage through reforms to and regulation of the private health insurance market. Based on our research, I feel confident saying that the DC Health Benefit Exchange is at the forefront of efforts to advance health equity among the commercially insured population. Excuse me. One area in particular where DC is serving as a model for other marketplaces and states is with respect to what we call equity-based insurance design. That is, adjusting what an insured consumer pays for covered services in the form of deductibles, copays, and coinsurance in a way that is intended to promote equity and reduce disparities. For background, in DC, all health insurers offering coverage on the marketplace need to offer a set of plans that conform with standard cost-sharing parameters. This makes shopping easier for consumers. They know all standard plans are going to have the same out-of-pocket costs and can instead focus on comparing other plan features. For the current plan year, DC eliminated cost-sharing in its standard plans for a range of items and services necessary to care for and prevent diabetes, which disproportionately impacts DC residents of color. Under this framework, standard plans in DC have $0 cost sharing for preferred brand insulin, non-insulin diabetes medications, diabetes supplies, and a variety of lab tests for diabetes patients, as well as for primary care office visits, yearly dilated retinal exam and foot exams, and unlimited nutritional counseling visits for patients with a primary diagnosis of type 2 diabetes. For context, other states might cap insulin between $25 and $100 a month, and some marketplaces have even required some plans to offer insulin with $0 cost sharing. But the number and range of services that DC has protected from any cost sharing is far broader than any other market today, and it is serving as a model. Maryland's marketplace has been closely looking at DC's requirements as it revises its standard plan rules, and at least one other state reached out to my team to find out more about DC's approach after we wrote about it for the Commonwealth Fund. The reason they're reaching out and adopting DC's approach is because crafting more equitable benefit designs is not simple. While it may sound pretty straightforward to pick some services and cut their cost sharing, there are a lot of federal requirements that make it far more complicated to navigate in practice. Additionally, insurance regulatory offices don't traditionally have a lot of internal clinical expertise, so DC had to do a lot of research to figure out the specific lab tests, exams, and other services to target. Perhaps just as impressively, as you just heard, DC hasn't stopped with diabetes. For the 2024 plan year, as Alana just discussed, it will require standard plans to lower cost sharing and thereby reduce financial barriers to care for pediatric, mental, and behavioral health. You may be wondering how DC went about picking these conditions. That is the work of its Social Justice and Health Disparities Working Group, which it established in the fall of 2020. This group includes a diverse array of stakeholders and has proactively sought out experts in health equity and other relevant areas like Alana and her team at Children's National to guide and inform DC's work. I also want to briefly mention a couple other initiatives DC has undertaken. First, DC requires that its insurers pursue health equity recognition and accreditation from the National Committee for Quality Assurance. This certification asks insurers to do things like collect race, ethnicity, and other demographic data from their members and to provide culturally and linguistically appropriate services. The only other state or marketplace to have such a requirement currently in place is covered California, although others are again following in DC's footsteps and looking at adopting this requirement in future years. Finally, the DC Health Benefit Exchange has also been engaging with insurers to figure out how to eliminate discriminatory clinical algorithms and diagnostic tools from their IT systems and the systems of their network providers. The most publicized version of this is the use of race in a measure of kidney function known as EGFR, which has the effect of delaying care for Black patients until their kidneys are in worse condition than required for white patients. Much of the responsibility for identifying and stopping usage of these biased algorithms and tools lies with medical professionals and their societies, but DC has been pushing its insurers to make sure they're doing their part too. So just want to reiterate, DC strikes me as leading the way when it comes to health equity in the commercial insurance landscape. It's a model for other marketplaces and states, and I'm excited to see what it does next. Thank you for this opportunity to speak to you all.
Thank you. And thank you to this panel of public witnesses. It's always good to hear that the district is a leader in the health insurance space and is serving as a model for others as well. I don't know if is Ms. Campbell, are you still on the Zoom? Checking to see, I had a question for her. Okay, I think she might have had to hop off. Okay, so I don't have any further questions for this panel of witnesses. Thank you so much. Again, you will be, and I don't see any of my colleagues here. So you will be, I guess, sent back to the attendee room, and the next panel of public witnesses will be promoted here in a minute. If you just give us a moment for that transition to take place. The next 5 is Louis Gallego, Jeffrey Credit, Homer Thomas, Jay Yarbrough, and Sean Townsend. For the public witnesses who are waiting, you do have to accept our invitation. So when your screen, you do have to click yes that you want to be elevated as a panelist. Okay, I see number 6, Luis Gallego. You can unmute and go ahead and present your testimony.
Good morning, Chairwoman Henderson and members of the Committee on Health. My name is Luis Gallego. I am testifying on behalf of my mother, Maria Naranjo. My mother has been caring for children for 20 years and loves working with kids. 10 years ago, she opened her own child care center. I'm proud to say that she now has 3 employees and cares for 12 children. I want to tell you how important healthcare for childcare has been for my mother and to ask that the program continues in the future. As a business owner, my mother has had to purchase her own health insurance. Thanks to the Affordable Care Act, she was able to buy insurance to the individual market, but the cost was becoming an issue. Unfortunately, my mother has arthritis and other pre-existing conditions, so it was critical that she have health insurance. She's had to have 2 surgeries and she would not have been able to afford them without coverage. Health insurance was just not something that she could ever go without. Each month, my mom was literally counting cents to try to cobble together the money to pay her premiums. It was difficult, and it meant she had to sacrifice things, and it kept getting more difficult with premiums going up each year. Before healthcare for childcare, my mother was paying almost $600 a month on her health insurance. Now, thanks to the program, she pays no monthly premium. I want to stress how important this program is to my mother and people like her. As I said before, my mother loves caring for children, and she wants and needs to keep working, but she needs to stay healthy to keep working. She needs treatment for her arthritis, so it is life-changing to be able to go from spending your last dollar each month on health insurance to knowing you're covered, no matter how tight money is. For us, it is crucial this program be renewed and continues to be funded. It truly has been life-saving for her and her small business. Thank you very much for letting me share my mother's story, and I will be happy to answer any questions you might have.
Thank you so much. Mr. Credit?
Good morning. Can you hear me?
Yes, sir. Go ahead.
Okay, thank you. Good morning, Chairman Henderson. My name is Jeffrey Credit, and I'm the founder and CEO of Community Educational Research Group with community-based centers in Ward 7 and Ward 8. I'd like to thank you and the council for this opportunity to express my views. Much has happened in the field of early care and education over the past few years, with an extraordinary and much needed focus placed on the wonderful teachers and staff of ECE centers. With the help of the City Council, Mayor's Office, advocates, and stakeholders, the working conditions of ECE staff have vastly improved. Central to the work that's been done is the new healthcare benefits program for ECE employees. We were contacted by Assistant Superintendent of Education, Sarah Mead, to become part of this prototype program. We interacted with the staff of DC HealthLink, Christian Naro, Mila Kaufman, and others, giving them advice and insight on the workings of the childcare industry in an effort to streamline the eventual forthcoming process. The staff of DC HealthLink have been absolutely fantastic, putting together a large, far-reaching program in a short amount of time. They were always accessible, always available to answer any questions or clarify any points of concern. As with any new major program, there were some hiccups and bumps in the road, but the staff at DC HealthLink handled these as professionally and as quickly as possible. The lines of communication were always open, and we had no problem in getting clarification to any issues that may have arisen. This program has and will be a godsend for the staff of all ECE centers who participate, and crucial to the hiring and retention of ECE staff. This, along with the Pay Equity Fund for ECE staff members, will allow all centers to attract more motivated, educated, and qualified staff, thereby increasing the quality of services and education delivered by ECE centers. At my centers, 13 staff members who previously did not have coverage now have excellent healthcare benefits at no cost to themselves and reduced costs to the center. And these benefits are available to all current staff members and staff members that are going to be coming into the center. Community Educational Research Group is now part of the Healthcare for Childcare Advisory Council. We assist and advise DC Health in an effort to streamline the process of obtaining coverage, relaying information to other ECE centers, clarifying any issues, answering questions, and being a messenger and a go-between for the childcare community and DC HealthLink. And I just want to say to the council and the mayor's office and DC HealthLink, just thank you for this outstanding program, the benefits of which are immeasurable and whose positive impacts are going to be felt for years and years to come. This is really, really going to boost childcare. It's going to give a great boost to our staff, and it's just a wonderful program. I love it. My staff love it. Thank you very much for allowing me the time to speak, and be happy to answer any questions.
Thank you, Mr. Credit. Please do stay for questions. Mr. Thomas? Need to unmute, Mr.
Good morning, everyone.
Good morning.
Chairman Henderson and members of the Committee on Health. My name is Homer Thomas, and I'm the owner of Washington Academy Preschool. I'm pleased to offer testimony before you today regarding DC HealthLink and the positive impact it has had on my business, my employees, and my family. More specifically, I want to highlight what a blessing the Healthcare for Childcare program has been for us. Washington Academy Preschool is a bilingual preschool that I operate here in Ward 8. We're proud to offer the creative curriculum in either English and Spanish or English and Portuguese. I opened this facility after retiring as an assistant principal from the Prince George's County Public School System. I love working with kids, and throughout my career, I found, after retirement, I found that I missed the connection with kids. And so in 2020, I opened the Washington Academy Preschool as a home-based program. We currently only have 3 students, but we have slots for 9 students. Also here, we have 4 dedicated employees who are very important to us. I should add that I'm also a retired veteran, military veteran. I served in both the U.S. Army and U.S. Navy, and I was called up for 9/11, and I served then as well. I have 2 sons. While I get healthcare through the VA myself, my sons can't. So that was a problem when I had to provide healthcare insurance after retirement from the school system. But now that I'm retired and I have my own business, I needed coverage for my sons who are 4 years old and 15 years old. So this is where the healthcare for childcare program helped my small business and my family. We want to support our employees in every way we can, and we've wanted to offer them health insurance benefits previously, but we weren't able to afford it. Thanks to the Healthcare for Childcare program, all 4 of my employees and myself have coverage with free monthly premiums. As an individual, I wouldn't have been able to afford that coverage for myself and my sons. As an employer, I definitely couldn't afford it for my employees. Quite simply, getting my employees insurance coverage simply wouldn't have been possible without the Healthcare for Childcare program. So I want to thank the mayor, the district council for this program, and it allows us the ability to focus on providing bilingual education, which is much needed in Ward 8 and throughout the District of Columbia, and providing support for our students who deserve the best. Thank you very much for this opportunity to share my experience, and I'd be happy to answer any questions that you might have for me.
Thank you, Mr. Thomas. Jay Yarborough? Okay, don't see Jay. All right, Mr. Townsend?
Good morning.
Good morning.
Good morning, Chairwoman Henderson and members of the committee. My name is Sean Townsend, and I'm President and CEO of the Restaurant Association, Metropolitan Washington. RAMW actively supports and promotes the Washington, D.C. area food service industry on behalf of our 1,400 plus members, which includes restaurant owners, operators, food distributors, and service providers. Our membership soundly represents the diversity of the industry in the district. Our industry before the pandemic employed over 65,000 individuals in the District of Columbia, making restaurants the second largest private employer in the district, accounting for 8% of employment in the city. In DC, 96% of full service restaurants are independently operated, meaning a majority of local restaurants are small businesses, including RAMW. RAMW has partnered with the DC Health Benefit Exchange Authority and has been enrolled in the Small Business Health Options Program, also known as SHOP, since 2014. Our partnership with DC HBX has been critical in keeping restaurants informed and aware of healthcare options available to small businesses and of incentives that are available to them, especially during the height and recovery of the pandemic. During our October 21, September 22 grant period, RAMW supported the DC Health Benefit Exchange Authority in its efforts to engage small business owners and their employees in securing and retaining quality, affordable health insurance through DC Health Link, the district's online marketplace, as well as through individual market for employees of owners who do not offer group coverage. RAMW partners with DC Health Link to develop strategies that provide options to restaurants that work within their operating schedules and enable opportunities to have their concerns addressed directly with brokers that regularly work with the hospitality industry. Our outreach and on-site visits to educate and encourage enrollment in employer-sponsored plans resulted in direct engagement of 360 small business restaurants in the district, has resulted in multiple broker referrals and follow-up appointments over the grant period. In 2022, as part of our engagement strategy, RAMW hosted monthly Broker Business Connect virtual sessions targeted to DC small business restaurant owners, operators, and representatives to provide a space for them to connect with a broker who answered questions related to employer-sponsored coverage, incentives, concerns, and best practices when considering offering coverage. Additionally, RAMW was able to utilize our networking and special events for lead generation and reinforcement of messaging relating to enrollment in SHOP through branding, materials, and in-person conversations. Over the grant period, our networking events were attended by approximately 300 DC small business, restaurant industry owners, operators, and representatives. Special event support during the grant period, including our January 22 RAMW State of Industry Seminar, March RAMW Annual Meeting, and July RAMI Awards Gala, all of which were well attended by small business restaurants for industry updates and networking opportunities. These events allowed us to engage more than approximately 2,300 restaurant industry owners, operators, and representatives about DC HealthLink. On our digital platforms, RAMW features DC HealthLink to reinforce messaging, incentives, and events in our monthly e-newsletter and dedicated presence on ramw.org, including prominent placement via digital banners and images on the homepage and internal sidebars dedicated healthcare section for updates and blog posts related to DC Health Benefit Exchange Authority. Our strategy for engagement also included providing DC HealthLink information during food safety and alcohol manager training courses held on site at the RAMW office, being provided to approximately 100 employees that work in DC small business restaurants over the grant period. In addition to RAMW's engagement activities, we provided feedback, insights, and support of DC HBX robust schedule, programming, and activities throughout the year, including amplification of special town halls and the annual Power Up DC Small Business Summit. These engagement strategies and outreach methods with members directly through in-person and virtual engagement has allowed RAMW to be trusted source in providing current and accurate information about the programs. Thank you for your time today, and I stand ready to answer any questions the committee members may have.
Thank you. Thank you so much to this panel of witnesses. I wanted to start with talking to Mr. Gallego, Mr. Credit, and Mr. Thomas. It's always a good thing when we get to hear people who benefit from a program that we put in place as part of the ECE fund. And I'm curious from you three, what was the reaction from your employees when you told them that this was going to be an opportunity for them to be able to get health insurance? Anyone can go.
Well, this is Mr. Credit. Speaking for me, my staff was excited, but I think I was more excited for them than they were for themselves, because I knew what a real positive that this would be. And my staff were definitely excited because it obviously gave them a chance to get some quality healthcare. And we picked one of the Blue Cross Blue Shield gold plans. So, they're able to get themselves, their children on the plan, and that's one less thing that they have to worry about in life. And when your staff is happy and confident and with less worries on their plate in their lives, then you have a better employee or a more well-functioning employee coming into your center and into your business, which makes everything just operate better. That's just one less thing that staff have to worry about.
Anyone else want to weigh in?
Well, I want to contribute as well, but I was going to allow Senor Gallego Sí,
Yeah, I'm here.
Pero ya, puede hablar si quiere. Yeah.
Yeah, okay. So my mom literally cried. She cried. I mean, it was life-changing for her. She couldn't go without health insurance, so she had to pay a big out-of-pocket premium. It was $600, and every month that's $7,200 a year. That's a lot of money, and she loves what she does. She loves caring for kids, but that's a lot of money to spend on insurance. So when she heard about the program, she literally cried. I mean, it was life-changing for her. And she has pre-existing conditions. Her premium was very high. I mean, she got her car insurance like a week ago, and she was as excited as when she got her green card. I can tell you that much.
Wow. Yeah.
Mr. Thomas, I want to ask you I think you
No,
said,
go right ahead. Mhm.
I think you said you only have 4 employees.
Yes.
Let me ask a slightly different question. So right now, the healthcare for childcare program is only for DC residents who are employed. And I'm not sure if you have any employees who are not district residents.
I do have one who's not, yes.
Okay, so, I think one of the things that was suggested to us that we make a change in the legislation that would allow for anyone who is employed at a district facility to be able to participate in this in a similar fashion as if anyone got healthcare from their employer in the private market, right? We have, let's say, you work for a small business that's, down the street on Pennsylvania Avenue, but you live in Maryland, you still are able to seek healthcare through your employer. What are your thoughts on that?
I absolutely agree with that. I think that would be wonderful. It'd be a great advantage, and it would really serve the mostly people who work in early child care. They're women, of course. Most of the employees are. And the employee that I have who works out of state, she actually works right across the line from where I live in Maryland, right? And she has 2 small kids, and she was actually on Medicaid. The kids were actually on Medicaid, and so because she couldn't, obviously she couldn't afford it, and even now she was just overwhelmed when she found out. And I'll tell you the reason why. It's sort of a lengthy story, not a long story. Well, she has 2 kids in El Salvador still. And so she didn't want to apply for any benefits like TANF or anything like that, because if she's a public charge, so to speak, or receiving benefits, it's almost impossible for her to bring her kids from El Salvador here. And so she was caught in that bind. And so because of the healthcare for childcare workers program, she was able to receive the childcare and not receive Medicare, not have Medicaid for her kids or anything, as well as for herself, and not have to be considered receiving any welfare benefits or anything. So I think it would be great if the program was open to all childcare workers in the district. I think not necessarily residing in the district, but residing wherever they choose to reside or can afford to reside.
Got it. For the 3 of you, what, if any, other suggestions administratively would you suggest for this program to go more smooth? In some ways, you all are like the guinea pigs because you got in on the first round, and so this is an opportunity to improve the program. If you have any suggestions on how we can do better.
The one thing that I always kept hearing from my colleagues is that prior to putting the program together, that not much information was sought out on the childcare community and how the childcare community, how it works. And so you kind of had a program that you're trying to mesh together with an industry that the program didn't really know too much about. And though that caused a little bit of it just made the process a little bit longer. So that's one of the things. to be able to get out into the childcare community a little bit more and let people know about the program. Because there's some people out there who still don't know about it. There's some people out there who are, still kind of leery about it because they're just leery about OSSI in general. So, the combination of, OSSI and a program that you don't know much about, it kind of set people back a little bit and made them, not participate as fully. But I think they're starting to take care of some of those programs, especially with the advisory board. So I definitely expect the workings of the program to be a little smoother in the future and bringing on other centers.
May I jump in right now?
Sure.
Just sort of comment on what has been said so far. After COVID, and I think the child care for healthcare workers, for early child care workers, I think it was like a life preserver. You threw a life vest because it's hard to bring kids back in and workers with the low earnings. I mean, this was one of the best things you could have done was give them. Yeah, it really was. So I mean, I want to applaud you. I can't thank you guys enough for what you guys did. You really did. You knocked a home run and touchdown on Super Bowl. You deserve it. I mean, you really do deserve it, Chairman Henderson. You really do.
Awesome. Well, thank you all so much. Mr. Townsend, thank you for your testimony. I don't have any specific questions. I think that your members have been using the SHOT program for much longer. So I wanted to get some feedback from the new folks who are now engaging and interacting with the health DC Health Link. Thank you all for your testimony. As I said to the others, I don't see any of my other colleagues, so we're going to move on to the next.
If I could say something, Mr. Townsend, real quick, could you shoot me your contact information, sir?
Be happy to. I'll be happy.
I gotta always do business.
Thank you. Yes, sir.
Thank you all.
All right.
Thank you.
All right.
Okay, we're going to call up the next panel. Again, once you're going to see an invitation that you need to click yes to affirmatively be elevated. Nicole Quiroga, apologies again if I am butchering your name. Angela Franco, Tara Pavo, Frank Tucker, and Florencia Del Vela. Give it a minute for these folks to come on. Okay, I see the first two, so we'll go ahead and get started in the interest of time. Nicole, if you want to unmute and start your testimony.
Thank you. Thank you. Good morning, members of the DC Council on Health and Committee Chairman Christine Henderson. Excuse me. My name is Nicole Quiroga, President and CEO of the Greater Washington Hispanic Chamber of Commerce, and I'm here today to testify on behalf of the DC Health Benefit Exchange Authority, which manages and operates the district's online health insurance marketplace, DC Health. Our chamber represents over 800 members from across the region, with more than a third being business owners in the nation's capital. The mission of the chamber has always been to support the growth of Hispanic and other minority businesses in the DC metro region through education, networking, and advocacy. Since July 2013, the GWHCC, in partnership with DC Health Link, has engaged in and facilitated the enrollment process for individuals, families, and small businesses. Today, we are pleased to testify on behalf of the phenomenal and tireless efforts that DC Health Link, its staff, and its partners put forth to provide high quality and affordable healthcare insurance to the Hispanic community in the District of Columbia. Some of our most recent outcomes in the area of education and enrollment, our chamber has partnered with DC Health Link to host the very popular virtual one-touch enrollment events, which provide DC residents with easy online opportunities to enroll in quality, affordable healthcare. This initiative is executed with the support of Carlos Rosario International Charter School, the DC Department of Human Services, assisters from various NGOs such as Mary's Center, Whitman Walker, and La Clínica del Pueblo, and insurance brokers that are well-versed in how our community moves. This year, virtual one-touch enrollments took place every Saturday when open enrollment started. In total, we touched 400 individuals with families with 200 new enrollments, 180 renewals, 50 Medicaid applicants, and 100 Alliance applications. During the DC HealthLink Hispanic Enrollment Week of Action, we partnered with DC HealthLink, MOLA, and the American Academy of Pediatrics to host a virtual town hall conversation, New Year, New Challenges, which got 85 registered in the conversation. From October 2022 to January 2023, we hosted 50 outreach and educational online sessions in total touched about 3,000 small business owners to inform them about the benefits of DC HealthLink. Through our online networking events, we were able to touch, promote, and disseminate information during our 20 network webinars, 12 co-sponsored events, and 12 women group events, and of course, our annual business expo. GWHCC is an active member of the Hispanic Advisory Committee, where we learn about policy updates, marketing trends, and outreach strategies to keep the community engaged with DC HealthLink. Over the last fiscal year, we sent 20,473 emails, e-blasts, and newsletters with DC HealthLink information. In association with DC HealthLink small business partners, we play a significant role in hosting DC HealthLink's Power Up DC every year. During Power Up DC, government and private sector representatives present the latest business trends and contracting opportunities for small businesses. We also partner with our Hispanic media outlets like El Tiempo Latino, Washington Hispanic, El Sol, in promoting DC HealthLink Small Business Marketplace program. We are very proud of our award-winning DC HealthLink Marketplace and respectfully request the council to continue to support the mission of the DC Health Benefit Exchange as they continue to provide DC residents accessibility, dignity, and the basic human rights of health insurance coverage. Thank you for the opportunity to testify.
Thank you. Ms. Franco?
Yes, thank you. Good morning, Chairman Henderson and members of the committee. My name is Angela Franco. I'm the president and CEO of the DC Chamber of Commerce. The DC Chamber is pleased to submit testimony on the performance of the Health Benefit Exchange Authority over the last fiscal year and this fiscal today. The DC Chamber represents over 1,200 member companies of all sizes and industries and the hundreds of thousands of individuals they employ. Through our partnership with DC HBX, which manages and operates DC HealthLink, the district's online health insurance marketplace, we host outreach activities to connect businesses with the exchange's small business marketplace, and we work closely with brokers to assist with their enrollment. Within the past year, we have sent over 900 emails to members, partners, and followers, participating in marketing and promotional campaigns. We have also engaged in various communication strategies via social media, outreach, e-blast, webinars, telephone messaging, and in-person events. We've made more than 350 phone calls to small business owners and over 380 in-person connections with small businesses, referred over 50 businesses to DC HealthLink, and enrolled over 11 small businesses. For greater exposure, all DC Chambers newsletter and virtual convening announcements include DC HealthLink banners, which appears as a tagline at the bottom of the collateral materials directing businesses to the DC HealthLink website. To facilitate district resident small business awareness of the American Rescue Plan, DC HBX held 2 informational webinars. The Chamber participated and partnered in these webinars and heavily marketed the events to our members and contacts via electronic news blasts and emails. In collaboration with the DC Small Business Development Center at Howard University School of Business, the Chamber also took the initiative to host its own ARP webinar entitled Let the American Rescue Plan Rescue You. All events were very, very well attended and received. For anyone able to attend the webinar, DCHBX created and posted videos on the American Rescue Plan and the COVID-19 relief laws to make information more widely available to the business community. To further increase health insurance enrollment opportunities, DCHPX removed many barriers to enrollment and offered a COVID-19 special enrollment period. Both the American Rescue Plan open enrollment and the COVID-19 special enrollment period provided DC residents and small business additional opportunities to enroll in private health coverage. The only difference between the two is when coverage would begin. After learning that communities of color are disproportionately impacted by COVID-19 and are vaccinated at a much lower rate than other ethnic groups, DC HealthLink immediately acted to address the disparity. In partnership with the Kaiser Permanente Center for Total Health, district government agencies, and community organizations, DC HealthLink hosted a virtual lunchtime town hall conversation entitled Focus on the Facts, COVID-19 Vaccines and Communities of Colors. This interactive town hall focused on the vulnerabilities and impact of COVID-19 and communities of color, dispelling myths about COVID-19 vaccine and barriers to vaccination. In addition, DC HealthLink shared information about enrollment opportunities during the pandemic and the importance of enrolling in quality, affordable health insurance coverage. Additionally, to aid DC residents during the pandemic, all deductibles, copayments, and coinsurance for diagnosis, testing, and treatment for COVID-19 were waived. We partner extensively with DC HealthLink also in the Power App. That is an event that is targeting the business community in Washington, DC. And I know firsthand, I don't know if you're aware, Councilmember Henderson, but I worked with them for 3 years. So I know firsthand they're always looking for opportunities in how to better reach the business community, what programs to create under the circumstances that the city is going through. So for instance, during the pandemic, we created a special program to reach out to people that were losing their jobs and making sure that this information is really reaching every resident and every business in the District of Columbia. We ask that you continue to support the program. I think this is a great and very important program for residents and for businesses to be able to offer affordable, accessible health insurance to all. Thank you very much and happy to answer any questions.
Thank you. Tara Pavo. And again, apologies if I'm pronouncing your name incorrectly.
That's okay. Thank you so much. Good morning, Chairperson Henderson and members of the committee. Thank you for the opportunity to testify today. My name is Tara Pavo, and I am the Social Services Director at Mary Center. Mary Center employs 2 in-person assisters who implement our Health Benefits Exchange program. Mary Center and the Health Benefits Exchange Authority have had our partnership for nearly 10 years. At Mary Center, we witness firsthand the impacts our in-person assisters have in supporting DC residents accessing health insurance providers through the DC HealthLink, the Affordable Care Act online health insurance marketplace in DC. Within the calendar year of January 1st through December 31st, 2022, our 2 in-person assisters supported 2,477 DC residents and their families obtain health insurance. We conduct in-person and virtual outreach events in English, Spanish, and Amharic to educate our community of health insurance benefits and enrollment processes. We are present in the community during evening hours, throughout weekends, and host indoor and outdoor community events. Our dedication and tenacity to maximize opportunities for uninsured DC residents to enroll in health insurance speaks volumes to Mary Center's Health Benefits Exchange program's perseverance to ensure the highest percentage of residents obtain health insurance coverage. The DC residents we serve express their gratitude for providing culturally specific services in their native languages, specifically with increasing health insurance literacy and enrolling in qualified health plans. We have appreciated the partnership and leadership of the DC Health Exchange of the DC Health Exchange, working with us to ensure the staff are trained and supported in their roles and to help identify and arrange events that can best meet those who still lack insurance. Thank you for this opportunity to testify, and I will be happy to answer any questions you may have. Thanks again.
Thank you. Mr. Tucker?
Good morning, Chairman Henderson and members of the DC Council Committee on Health. I am Reverend Frank D. Tucker, Pastor Emeritus of the First Baptist Church of Washington, DC, and Chairman of the Board for Leadership Council for Health and Communities. I'm pleased to provide testimony at the FY 2022-23 Performance Oversight hearing and on behalf of the DC Health Benefit Exchange Authority. LCHC is an organization of clergy leaders, medical professionals, public and community leaders working together to help African Americans and other communities of color eliminate health disparities and promote healthy communities throughout comprehensive health programs. I'm pleased to speak on behalf of the work LCHC has done and is doing to partnership with the DC Health Benefit Exchange Authority. We have had the privilege of serving as an sister organization of the DC Health Benefit Authority since its inception in 2013. All of us are aware of the great work the exchange is doing for DC residents in providing residents with access to health insurance through the DC Health Link. I am especially supportive of our collective work in partnering with faith institutions and lay organizations to ensure access to quality, affordable health insurance. With the success of the Affordable Care Act, which we affectionately call Obamacare, many uninsured residents have finally gained access to health insurance coverage. The LCHC board receives regular reports from in-person assistants. Thus, we have become aware of the diligent outreach efforts of the LCHC assistants throughout the COVID-19 pandemic and throughout the year. Hundreds of calls have been made to assist persons with enrolling in health insurance after losing their jobs and losing health insurance coverage through their employees. We strive to reach residents, and our outreach activities are targeted to persons deemed hard to reach. We have built relationships with clergy organizations, neighborhood businesses, and houses of worship that allow continuous access to residents who need health insurance coverage. During the DC Health Link's African American Enrollment Week of Action and Faith in Action campaign, we conducted socially distanced outreach to barbershops, beauty salons, such as Midtown Barbershop, John Scott Cuts, My Three Sons Unisex, and Expert Barbershops. Popular local establishments like Lidl Pizza and Chick-fil-A participate in takeout sticker tag campaign by affixing health insurance deadline stickers tags to their takeout boxes and bags. We lift up the advantage of having health insurance coverage through our virtual worship services, church bulletins, and programs at faith institutions throughout the city. Messages regarding DC Health Link and the need for health insurance are delivered from the pulpit. In an effort to meet people where they are, assisters have participated in numerous other outreach efforts, including DC Metropolitan Police Department's Beat the Streets event, Martin Luther King Day Health Fair, AMC movie theaters, healthcare a child care enrollment at the DC Armory, as well as health fairs and COVID-19 vaccination pop-up clinics. All our work is done to help improve individual and community health. To quote Dr. Martin Luther King Jr., we deeply believe that of all the forms of inequity, injustice in healthcare is the most shocking and inhuman. This work is a solemn task, a sacred duty. I commend the leadership and staff of the DC Health Benefits Exchange Authority, and I pray that they will continue to be successful in their efforts to service DC residents. Respectfully submitted, Reverend Frank D. Tucker, Pastor Emeritus, First Baptist Church and Chairman of the Leadership Council for Healthy Communities. Sorry for the preachment.
Thank you, Reverend Tucker. Ms. Del Villar.
Good morning, Chairman Henderson and members of the Committee on Health. My name is Florencia del Villar, and I am the owner of the Colores Spanish Immersion Montessori in Ward 4. I'm pleased to talk with you today about the Healthcare for Childcare program and how it has helped my school and the teachers that work there. The Colores has been serving families in Manor Park, Tacoma Park, Silver Spring, Brightwood, and Petworth for 14 years. Our mission is to inspire love of self, love of others, and love of learning across our community of children, staff, and families. We use the Spanish immersion language model, the Montessori method, and the anti-bias, anti-racist goals to center children's autonomy and joy. Our books, lessons, and materials purposefully uplift human diversity and create opportunities for continued learning and relearning. We currently have more than 50 students enrolled in our program, and we have a dedicated staff of 19 women, all immigrants, who care for and teach these children. Half of these women have been working at the school for at least 10 years. As an employer, the Healthcare for Childcare program has come as a great relief. I believe that healthcare is a basic right, and it has always been one of my hopes as an employer to be able to offer it. However, the financial reality is that it has been too expensive for me to offer. The cost of doing business goes up each year with more training requirements, necessary salary increases, and general inflation. I can't pass the cost to parents because childcare is already too expensive. I'm incredibly proud to now be able to offer my staff access to affordable healthcare, and I wouldn't be able to do it without this program. Also, I'm very happy that 7 members of my staff are getting health insurance with totally free premiums. I encourage the DC Council to continue funding this program. DC has always been a model for best practices for the care and education children receive. This program, though, feels like the first time that DC has focused on the adults who provide the care. Having healthcare coverage is key to providing quality care and instruction to young children. I know that many center directors in the district aren't participating in the program this year because they're afraid that there won't be any funding next year. They don't want to begin offering their staff something they won't be able to afford if the program ends. I had to be really honest with my staff, so they understood that if the subsidies end, I won't be able to continue coverage. But given how important healthcare is, I am enthusiastic to provide the coverage as long as I can. I also want to highlight how much I appreciate Mr. Cristian Narro. He made the process of enrolling really accessible. He answered all of our questions. He offered to come in person and speak Spanish, which was really helpful. He gave the teachers a sense of security and helped them overcome any skepticism about the program and that coverage. The staff at Health Benefit Exchange has been really helpful in navigating issues as well. The bottom line is that most of my staff didn't previously have coverage, and without this program, they wouldn't have insurance now. Something everyone deserves. Thank you so much for sharing my experience, and I'm open for any questions.
Thank you so much. I want to thank this panel of witnesses for your testimony and your feedback in terms of working with the DC Health Link Authority to provide health insurance for your staff, your members, and the various communities for whom you advocate for. I want to ask Ms. Delvar the similar question I asked to the previous panel. How many employees do you currently have at your school?
19.
19, okay. And I'm gonna guess, given the location of your center where you're serving the Brightwood, Tacoma, et cetera, that you probably have some employees who live in Maryland at this particular point. How would you feel about the council expanding the rules that would allow for you to be able to provide this insurance for all of your employees by nature of them working for a DC business?
Well, at the moment, the way that it's working is that the employees that live in Maryland but but work in DC are actually benefiting from the healthcare for childcare, and that's actually the game changer. Most of our teachers used to live in the DC area, but it was so expensive that they had to move to Maryland or PG County. But they were still working in DC. Our DC teachers were already covered by the DC exchange. So a lot of them were Mary Centers patients or Clínica del Pueblo. So, but the biggest game changer was that the teachers that had to move to Maryland because the city was getting so expensive, but were still DC workers, are now able to access the program and the benefits.
Thank you. Ms. Franco or Ms. Krogroga, I'm sorry, again, I apologize, but I know I am butchering it and I apologize. In terms of the feedback from your members, is there anything that would help in terms of improving the delivery of customer service that they feel like dealing with the Health Link, or are most interactions generally satisfactory?
I mean, I'll tell you that in my experience, they've always been very satisfactory. I don't really hear of any difficulties that they're having. And they always have a genuinely a great experience finding out what they need and then being able to access that.
Yeah, I agree with Nicole. I think that the work we all need to continue to do is really keeping our members informed, especially when it comes to plan choice. That is a great opportunity for businesses, and they can work around a budget and the budget they have available. And, employees can join any insurance company they want, or they can really have access to the plan they want, and the business can give us a specific budget that they can spend on the insurance. So it's just a matter of continuing educating the community and sharing the news. I mean, I want to say the news, but sharing the information.
Okay, thank you. I don't see any of my colleagues or committee members here. So I want to thank the public witnesses for testifying today. Please make sure that you submit copies of your written testimony to the committee so that we can include those in the record. But we are going to move on to the next panel. And so thank you again for your time. Okay. Again, for the folks who are just coming in, if you are currently a panelist and you're moving off, we'll put you back into attendees and you can choose to continue to watch from there. But we're going to bring on the next panel, Janice Davis, Mitzi Rodriguez, Virginia Ali, and Vida Ali. We'll give it just a moment to give those folks time to come on. Okay, I don't see Miss Davis. Miss Davis, if you are here and your name is just the period that we're seeing in the attendees, can you please modify that so that we can actually see your name? But we're going to move on to Mitzi Rodriguez. I see you here. If you could unmute and turn on your camera, and you can go ahead with your testimony.
Good morning, Chairman Henderson and members of the committee. My name is Mitzi Rodriguez, and I am the owner of Bellas Artes Child Creativity Center, located in Ward 5. Thank you for giving me the chance today to testify and to share our extremely positive experience and concerning the Healthcare for Childcare program. Bellas Artes is a bilingual. Bellas Artes is a bilingual center focusing on early childhood education. We opened in 2021, and our classes are taught by dedicated and experienced educators. We work with children from 6 weeks to 5 years old. Our classes incorporate traditional learning styles and hands-on experience. We currently have 6 teachers who are all bilingual, speaking both Spanish and English. In addition to our language immersion, we immerse our students in the arts and the outdoors. We incorporate music, painting, and gardening experience in our classes and care. We currently serve 26 students and have the capacity for 4 additional students. COVID has taught us all the importance of in-person instruction so students can best avoid learning delays. COVID has also taught us the importance of staying healthy. Our facility opened during the pandemic, and it was really important that teachers and students be healthy in order to provide our students education and care. Since we opened, I have wanted to offer our staff health insurance coverage, but I wasn't able to do that because of the cost. But now, thanks to the Healthcare for Childcare program, I can offer health insurance to employees who couldn't afford it otherwise. I'm very happy the Healthcare for Childcare program exists so that our students have health coverage. The program makes it possible for employees to pay no premiums, nor do I have to pay premiums as a small business. It has already made a big difference with our teachers. They feel more secure because they have coverage and are happier at work. As a small business owner, it's good to know that employees can go to a doctor if they get sick, get the treatment they need, and then return to work healthy. With COVID still hanging around, this is really important for our child care center. Thank you very much for the chance to share my experience. I will be happy to answer any questions you may have.
Thank you, Ms. Rodriguez. Ms. Davis. You unmute. You're muted, Ms. Davis. Oh, now we can't see you. If you can hear me, you're still muted.
My phone is.
We can hear you now. Okay, we cannot hear you now. You are now muted, but we can see you.
Okay, now are we together?
Yes, we are together. Good
Perfect.
afternoon
Okay.
or morning.
Great. Good morning. It is a pleasure for me to come before you today at this important hearing of the Health Committee. I am Janice Haynes Davis, an insurance broker and owner of a small financial services and insurance brokerage business in Tacoma, DC. We are the Living Capital Group, and I'm also a 4th generation Washingtonian. I am a member of the National Association of Insurance and Financial Advisors, NAIFA, and the National Association of Health Underwriters, and serve as a representative for my peers in many capacities. Today, I'm coming before you as a partner with DC HealthLink and would like to speak with you about their proven service to our community. I have appeared before you all before today, but I would like to share with you my experience with HealthLink during the last few years and the pandemic and its impact on the business community. As you are quite aware, DC passed several emergency bills to assist the small business community to survive. COVID's impact on professional offices, restaurants, consultants, families, and individuals was disastrous. Owners struggled to pay rent, salaries, and continue to provide medical insurance coverage for their employees. During this period of uncertainty and anxiety, DC HealthLink stepped in and permitted employers to postpone payment of the premiums so that they could continue to maintain their coverage. Personally, my clients were able to obtain subsidies ranging from $1,800 to $70,000. This was a job saver and a godsend because medical coverage during COVID was essential. Medical premiums were also limited. Just because many of you know, the crisis really is not ended. And it is difficult for businesses who've been in the survival mode to recover and adapt to our post-pandemic, ever-changing and inflationary environment in which we find ourselves. For me and for them, it has been wonderful to pick up the phone and get a yes when a client calls and asks, can you help me? I am behind and need time to pay my invoice. I'm not calling an 800 number, but a local entity that listens and cares.
Ms. Davis, we're having connection issues.
On a different note, I would like also. Oh, wow.
Ms. Davis,
Okay.
can you hear me?
Okay. Can you hear me now? Yes.
Yes, I can hear you. Your
It's actually
froze. So we had connection issues. We didn't hear about the last minute of what you said. If you turn off your video and just speak, we can hear you more clearly.
okay. I'm just saying. I certainly will. I will just stop saying. Were you able to hear me talk about the subsidies that they gave from $1,800 to $70,000?
We are now. Yes, ma'am.
I'm completely frozen now.
No, we can hear you.
Oh, okay, great. Basically, okay. On a different note, that I've been asked to participate in an exciting venture, the Social Justice and Health Disparities Working Group. This project is exciting, and having worked for over 30 years with insurance carriers, almost revolutionary. It is an interdisciplinary approach to health equity and complements the emphasis of the executive, DISB, and the council's priorities of equality in the areas, universities, public policy experts, and of health, examined programs, worked on ways that DC could. The emphasis was on people of color. For me, as an old sociology and political science major, this standard working group sponsored by DC HealthLink is monumental. This partnership has led to changes in plan design with an emphasis on those diseases like diabetes, heart. Now we are tackling the mental health crisis in our children and adolescents. This is an ongoing project that shows the desire of this independent board-driven entity, DC HealthLink, pricing and choice.
I'm so sorry.
I disappeared again.
Well,
no, I have written it.
Muddled at this point. So I don't know if you.
Okay.
I don't know if you want to sign out and sign back in. We'll move on to.
No, just go ahead and use. I've written the text.
Oh, okay.
And you have a copy of it. And I'm like in a place that's probably not working so well because I've been traveling. So you can just please take a look at it. It talks about many new things that we're doing, and
yes,
you can read it.
We do have a copy of your testimony, so we will take a look at that. Thank you so much for being.
Thank you, and I'm sorry about the interference.
No, it's
Bye-bye.
okay. That's the technology world that we are currently in. We understand. Our next and final witness is Nazim Ali.
Okay, thank you.
Who will be testifying on behalf of Virginia Ali.
Hi, good morning, Madam Chairperson, Chairwoman Henderson, and members of the DC Council Committee on Health. I would like to share testimony on behalf of the DC Health Benefit Exchange and DC Health Link. As you know, Ben's Chili Bowl is a staple in the DC community because we care deeply about the residents who live, shop, work, and play here in DC. Since 1958, we have been a neighbor, friend, and partner to many in this city. We take pride in our partnership and work with the DC Health Benefit Exchange Authority. The work the exchange does every day to ensure every district resident has access to quality, affordable health insurance is remarkable. Now in its 10th year in operation, DC Health Link has cut the city's uninsured rate in half and ranks #2 in the nation for the lowest insured. That is truly amazing. As many of you know, Ben's is a small family operated and owned business. It always has and it always will be. We believe in family and we take pride in treating our team members, neighbors, and guests like family. We are dedicated to creating a happy and positive environment in which our team members are excited to come to work. Providing them with access to quality health insurance coverage is a part of creating that environment. We have DC Health Link to thank for that. Since 2017, DC Health Link has made it easy and possible for us to provide our team members with affordable health insurance. We offer our team plans from one insurance company, Blue Cross Blue Shield, so that they can choose the best plan that fits their needs. At Ben's, we pay 65% of their coverage. Any small business owner will tell you that hiring and retaining team members can be challenging. At Ben's, we are proud to say that many of our team members have been with us for over 15 years, with a few over 30 years. Our philosophy is to take care of them as family. DC Health Link's small business customer support team has been great, and because they have made it so easy for us, it means we can focus on taking care of our business. What's more, our team members can log in and sign up for coverage on their own through DC Health Link's online portal. The process is easy for them and frees up administrative time for us. Additionally, not only are we a DC Health Link customer, but also a DC Health Link community outreach partner. We cherish the opportunity to support DC Health Link's creative and innovative outreach efforts to inform residents about health insurance. Each year since 2019, Ben's has participated in DC Health Link's 24-hour enrollment marathon, and we provide space for residents to enroll in health insurance. I vividly recall one year in which President Obama's former senior advisor, Valerie Jarrett, stopped by Ben's to lend support during the enrollment marathon. She and medical students from George Washington University volunteered their time to meet with guests and share information about DC Health Link. I believe a few residents even enrolled. The 24-hour enrollment marathon is always a delightful day at late night experience. While guests order their favorites from Ben's menu, they are introduced to the value of health insurance and enroll on the spot. Some other activities we were engaged in to help support outreach and enrollment include the 24-hour radiothon, where 4 different radio stations set up live broadcasts at Ben's and filled the airwaves with valuable information and letting listeners know that they could stop by Ben's to enroll in quality, affordable health insurance. During this past enrollment period, which ended yesterday, the 24-hour marathon was extended to become an entire weekend event. So we were pleased to be a part of that enrollment marathon weekend, starting Saturday mornings at 11 a.m., straight through Sunday evening at 8 p.m. Residents called, residents came by to get information and to enroll in quality, affordable health insurance before last night's deadline. We also placed DC Health Link signage around our restaurants, including table tents on countertops and tables and place cards with deadline reminders and all carry-out bags to remind guests that they can qualify get affordable health insurance through DC Health Link. Additionally, we did an e-blast to send out insurance information to our more than 20,000 person email lists. We posted it on our social media platforms and participated in the open enrollment kickoff events at the beginning of each enrollment period. DC Health Link has been a strong advocate and partner with small businesses in the district. During the pandemic, they provided small businesses with social distance floor and seat decals, masks, and hand sanitizers were extremely helpful in getting our guests to follow CDC protocols during the height of the pandemic. For as long as DC Health Link operates in the city, they can depend on Ben's as a customer and partner. We are inspired to work with DC Health Link we're inspired by the work DC HealthLink does and encourage them to continue the great work they do. It's so important for our residents, our families, and our communities. I'm sure, like many of us, we want this program to grow bigger and better for our residents. We would like to thank our mayor, Mila and Linda, for the opportunity to share our Ben's Chili Bowl DC HealthLink experience. Now happy to answer any questions that you have. Thank you.
Thank you. Thank you for testifying, and thank you to Ms. Rodriguez for your testimony as well. I appreciate so much public witnesses who take the time to share their experience, not just with HBX, but with all of our agencies, as it helps to inform the work that we are doing. I don't have any specific questions for either of you, and I don't see any of my colleagues here. So thank you so much for your testimony today. We are going to take a 5-minute break, which will allow for us to reorganize here. And the next person we'll hear from is Mila Kaufman, the Executive Director of the Health Benefit Exchange Agency. She will be testifying here in the chamber. So we need to make sure all of those kinks are worked out. So I don't even know if we call this a brief recess, but we'll be back in 5 minutes.
Testing 1, 2. Testing 1, 2, 1, 2. Testing 1, 2, 1, 2, 3. Testing 1, 2, 3.
Oh my God.
Oh, testing 1, 2, 3, 1, 2, 3.
Okay, we are back and going to get started. This is so exciting. We have before us Mila Kaufman, the Executive Director of the Health Benefit Exchange Authority, And as I mentioned off camera, I believe this is the first hearing, at least in my 2 years of having a government witness testifying in person. So I appreciate that your willingness to do this. We're gonna, before we go, you have a presentation as part of your testimony. Before we start with that, we're just gonna swear you in under oath. So if you raise your right hand, yes, okay. So please raise your right hand so we can see it on the video screen. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia in this committee is true, the whole truth, and nothing but the truth?
Yes.
All right, great. Please begin.
Good morning, Councilmember Henderson and Chairperson of this committee. It is a privilege to be here this morning with you. I'm Mila Kaufman, the Executive Director of the Health Benefit Exchange Authority. And I would just like to start by saying thank you so much for your support of us and the Affordable Care Act since you were a staff person at council and in recent years as a council member. So it's a privilege to be before you as chairperson of this committee. And with me, I have senior members of my team. I would just like them to stand up quickly and introduce themselves.
Hi, I'm Harvey Kemp. I'm the deputy.
Thank you very much.
Mila, if any of them are going to answer any of the questions, they'll need to come up to the table to do so.
Okay, thank you. All right, first, I just want to quickly give you some background about us, then talk about open enrollment, the Inflation Reduction Act, healthcare for childcare, emergency premium arrears relief under COVID, and our social justice and health equity work. So a little bit of background about us. We are responsible for the Affordable Care Act state-based marketplace here in DC called DC HealthLink. And even though we were the last state to start building our IT system back in 2013, we're one of 4 state-based marketplaces that opened for business on time and stayed open on October 1, 2013. And since we've opened, we've achieved near universal coverage here in DC with more than 96% of DC residents covered. We've cut the uninsured rate by half, and now DC ranks number 2 in the United States for the lowest uninsured rate. We are funded through an assessment on health carriers. We're responsible for more than $670 million in annual premiums. We cover about 100,000 people, both employers in DC as well as residents. And in fact, we cover nearly 5,400 district small businesses and nonprofits. And we work with more than 900 brokers who provide free help to our customers. A few words about our open enrollment, which just closed yesterday. And thanks to Ben's Chili Bowl for being open all night and all weekend to help us get folks enrolled. We have 27 plans from Care First, Blue Cross Blue Shield, and Kaiser Permanente for 2023 for DC residents. We also have standard plans, which have no deductibles for essential care like primary care, specialist, urgent care, and generic prescription drugs. And starting this year, our standard plans cover type 2 diabetes care without any cost sharing to the patient. So things like insulin, lab work, eye and foot exams, and medication and supplies, all without co-payments, co-insurance, and no deductibles. And thanks to the Inflation Reduction Act, more residents qualify for lower monthly premiums. In fact, thanks to the Inflation Reduction Act, residents can keep lower premiums through December 31st, 2025. Residents get approximately $36 million annually in lower premiums, and residents can get premiums as low as $11 a month. And on average, families save about $5,600 a year. We worked very closely with insurers, brokers, consumer and patient advocates, and many others to successfully advocate for Congress to extend lower premiums that were initially established under the American Rescue Plan and were going to expire on December 31st, 2022. Now I want to turn briefly to talk about healthcare for childcare. Healthcare for childcare through DC HealthLink helps OSCE licensed child development centers and homes to provide affordable health insurance for their employees. And free and lower premiums started this January, just last month, and are guaranteed for 2023. I want to briefly explain how the program works. So workers of OSCE licensed early child development facilities who live in DC and their families can get coverage through our individual and family marketplace, and their premiums for themselves and their dependents are free when they enroll in a Silver Standard plan. And there's a choice, either Kaiser Permanente or Care First Blue Cross Blue Shield, HMO, or PPO. Now, premiums are free. However, the patient is still responsible for out-of-pocket costs like deductibles, co-payments, and co-insurance. Also, you can get free or lower premiums for health insurance if you are a non-DC resident and you work for an OSCE licensed child development healthcare center or home. And I want to emphasize that if your employer, OSCE licensed child development center or home, has 100 or fewer employees, you can get lower premiums or free premiums as long as that employer participates. However, if your employer has more than 100 employees, then currently the only way to benefit from healthcare for childcare is if you are a DC resident who works for that employer. You can enroll in individual and family coverage. But if you are not a DC resident, currently you are not eligible. And I just wanted to draw that distinction. So if you work for an employer with fewer than 100 employees, OSCE licensed, then you can get free or lower premiums for your health insurance. And all employees qualify, including employees who may not be eligible for the wage supplement, part-time workers, undocumented workers. All of your employees qualify for the lower or free health insurance premiums. We also have continuing coverage option, which we developed through a lot of feedback from centers and homes. Some centers and homes already provide coverage, and so they wanted to continue to provide the coverage that they currently offer without disruption. So we developed a continuing coverage option for those qualified OSCE licensed centers and homes. For January 1 coverage, we have 61 employers enrolled, which is 94 licensed facilities, and we have 62 residents and their dependents enrolled for about 656 covered lives altogether for January 1 coverage. And out of the 61 employers, 33 did not offer coverage before healthcare for childcare. And now 121 employees, 136 employees and dependents together are getting coverage. 95 of those actually pay no premium. They get premiums completely covered, and 26 employees pay a reduced premium. Out of the 25 employers who offered coverage through DC HealthLink before healthcare for childcare, we've identified that enrollment actually increased, or the take-up rate. So more of their workers are actually enrolling in health insurance coverage, whereas before they couldn't afford to pay their premium share. And 3 employers previously offered outside of DC HealthLink before enrolling. We know from one of them that thanks to healthcare for childcare, 80% of their workers are now insured. In the past, only a handful were on their plan, and it varied monthly. A quick note about the Emergency Premium Arrears Relief Program, which you partially heard about from Janice Davis, one of our brokers. The emergency COVID-19 relief for employers and residents with DC HealthLink health insurance in arrears was established using funds from the American Rescue Plan. Mayor Bowser established this program to help employers and residents whose premiums were in arrears, who were behind in paying their premiums during the COVID public health emergency. And essentially the funding was for $19 million to help pay for those premiums in arrears. Council approved the funding in FY21 and 22. And altogether, 635 employers covering more than 6,100 people stayed insured during the pandemic, thanks to this relief, and close to 1,800 residents with individual marketplace coverage stayed insured during the pandemic. Now, I just want to say a couple of things about our initiative around health equity and addressing health disparities. A few years ago, we saw the pandemic data on race and ethnicity, and that was a spotlight on the systemic racism in healthcare, and also George Floyd's murder. Those 2 events caused a pause moment for my board and our entire team. And we wanted to act. We wanted to be part of the solution to get to a more just community and certainly a more just healthcare system. And just to share a few data points, COVID data points, compared to white Americans, Black Americans were hospitalized at 3.3 times the rate of white Americans and died at almost twice the rate of white Americans. Latinos were hospitalized at almost 4 times the rate of white Americans and died at 1.3 times the rate. So the pandemic inequities reflect a long history in the US of racism, inferior treatment, discrimination, and mistreatment of people of color in the healthcare system. And we wanted to help address that. A few examples of what racism, systemic racism looks like. And these are documented biases and how a bias impacts outcomes in healthcare and leads to health disparities. So studies show that some third-year medical students and while in residency believe that Black skin is thicker than white skin, that Black people have a stronger immune system than white people. None of those things are true, but race bias impacts how you diagnose and treat your patients. And this is a real life example from one of our health plans when a Black patient who went to the ER was treated for a drug overdose by the ER treating physician. It was an error because the patient actually should have been treated for a severe episode of sickle cell. But that kind of bias leads to worse outcomes and health disparities. We also know that financial barriers are a problem, and it disproportionately impacts communities of color in terms of access to care. And this is DC specific data. While all residents report, all types of residents report financial barriers to not being able to see a doctor, Hispanic and Latino residents at twice the rate of white residents report having financial barriers to care. And more than 1 in 10 Black residents report financial barriers to care, compared to 6.1% of white residents. So our board established a working group for social justice and health disparities. Various stakeholders were members, all of our health plans, the physician group, the hospital association, children's hospital, experts, brokers. And the group was facilitated by Dr. Dora Hughes, who's now the chief medical officer at CMMI at CMS. The work was supported by the Robert Wood Johnson Foundation. And the group was chaired by our board chair, Diane Lewis. The goal was not to displace or replace any important work, all of the important work that the city agencies were engaged in, that community leaders and providers and other payers were already doing in addressing health disparities. So the goal was to come up with specific solutions within our authority that we and our health plans can implement. The working group adopted unanimous recommendations, which then went to our executive board, which adopted those in July of 2021. And some immediate outcomes of that work is us changing our plan design to make our standard plans what we call equity-based benefit design plans, with the goal of eliminating financial barriers for medical care for conditions that disproportionately impact communities of color in the district. So we started with type 2 diabetes, which I spoke about. For next year, we've reduced co-payments for pediatric mental and behavioral health to $5. And that's huge, because for our bronze plans, for example, co-pays are $45. So reducing those to $5 will improve access for children in the district who are privately insured through us, either through job-based coverage of their parents or under individual and family marketplace coverage. Those folks who have standard plans will see their co-pays for office visits, certain lab work, and certain medications for pediatric mental health decrease to $5 starting next year. I see I'm short on time, so I'm just going to wrap this up, and I'm happy to take any questions you have about this effort. And I know you focused a lot on this, but I'll wrap it up by saying our health plans have been tremendous partners in this work. And in addition to taking certain quick actions, they are reviewing clinical algorithms and diagnostic tools that have bias and perpetuate health disparities or amplify those. So just to conclude, we've been recognized over the years for our IT system, for our consumer decision support tools. We ranked #1 for our decision support tools in 2017 and 2018. We've received multiple outreach awards, I should say, we meaning my team, who's been really incredible in all of this. And we were chosen by the Massachusetts Health Connector, which of course preceded the Affordable Care Act, and the Affordable Care Act is largely based on terms of the exchanges. We were selected by the Massachusetts Health Connector in 2017 to replace their old IT technology for their small group marketplace. And we provide the IT solution as well as ongoing operational support. And now their shop is the largest it's ever been. And I'll now conclude by saying it really does take a village. From day one, it took a village, and we appreciate all the help we've received from the mayors, from council members and their teams, from our business partners, from assisters, from brokers, from other government sister agencies, the faith-based community organizations, and business leaders. Thank you so much, and I'm happy to take any questions you may have.
Thank you. Is it possible for you to take down your screen share? Just so we're trying to be mindful of how things appear. Okay. All right, so I'm gonna put myself on a 15-minute timer, because I don't know if my colleagues will join, but also we'll take a periodic break as well. I actually first wanted to start with the news of yesterday that President Biden intends to end the public health emergency in May. I'm curious if you can share what that means for members in terms of cost sharing for some of the tools that they have been used to using to combat COVID-19, and what, if anything, the exchange is doing to inform enrollees about this change that is coming around test kits, testing, et cetera.
And thank you for that question. First, I'd like to talk about the biggest impact, which is redeterminations of eligibility for Medicaid. During the public health emergency and continuous coverage requirements, essentially state Medicaid agencies, including DC's agency, had to keep folks enrolled in Medicaid, meaning there were no redeterminations of eligibility. As a public health matter, it's important during a pandemic, certainly the worst we've ever seen in 100 years, to keep people covered. And so now that's coming to an end. And that's the biggest impact. So all Medicaid agencies will have to start making redeterminations for eligibility. And we're working very closely with the DC Medicaid agency to plan for that, to make sure that when people lose Medicaid coverage, that we get those folks covered. And so our plan includes proven strategies that we've used before the pandemic. And one of the things that we've done very well working with DC Medicaid is we share information. So we know who is losing their coverage. There are joint notices that are sent that informs the person who's losing their Medicaid coverage that they can come and enroll through DC HealthLink, that they may qualify for lower premiums, depending on their income. In addition to those joint notices, we also get monthly reports of folks who lose their coverage, their Medicaid coverage. So then we can, through mail, through phone calls, which is also very effective for us, and through email, reach out to those folks who are no longer eligible for Medicaid. So once DC's Medicaid program starts making their redeterminations, we will get those monthly lists from DC Medicaid, so we can reach out to those folks and get them covered through DC HealthLink.
And just to be clear, I guess this would qualify as an event that would allow for you to enroll them immediately without having to wait until open enrollment.
Correct. Thank you for clarifying that. Yes. So there's a federal special enrollment period that the Biden administration also established
Okay.
to make sure, and that's it, everywhere there's healthcare.gov, which is the federal platform. And states have the state-based marketplaces have the option of doing what the federal government does or doing their own. So we are looking at the federal special enrollment period. It seems to be time limited for 60 days, which may not be enough time. So we're looking at that. And when I say not enough time, typically it does take us several efforts to reach people who are no longer eligible for Medicaid, who've lost Medicaid.
Right.
And so we don't want anyone to miss out on a 60-day window. So we're looking at whether or not we want to do something longer.
Okay. All right. Well, we'll follow up on that as those redeterminations begin. And I think we're talking to Director Turnage later this month, so we can talk more about that. I just don't want for folks to be lost in the cracks, because I feel like for DC, for us to have such a high percentage of our residents who are insured, we want to maintain that as much as possible, especially when there's another option available to them that is not Medicaid. There was something that caught my eye from your PowerPoint presentation. You said that 27 plans, or that currently the HealthLink has 27 plans from CareFirst and Kaiser. Are you concerned about only having 2 companies? I believe at one point there were more. Can you talk a little bit about what that process is like for folks to come into the marketplace?
Sure. So our individual market, and we have the whole market because we have one big marketplace, so everyone gets the Affordable Care Act protections. It varies between 15,000 covered lives and 20,000 covered lives, depending on the year. It's a very, very small private market. And it's typically not enough of an incentive for carriers, for insurers to come in to compete for a few thousand covered lives. In the first year and second year of our operation, we did have Aetna participate. They found that they only had about several hundred enrollees. That's it. And so it wasn't a competitive market for them on the individual side to stay on. So they decided as a business decision to focus on the small group market. On the small group market, we have 3 United Healthcare companies, 2 Aetna companies, CareFirst, Blue Cross Blue Shield, and Kaiser Permanente. But the small group market is about 85,000 covered lives. And so it makes a big difference. Now, the way we've set ourselves up is we've tried to eliminate barriers to entry. So any insurer that wants to come in, we've made it as simple as possible to do that, meaning everything is sold through DC HealthLink. So once you're set up to sell through us, it's relatively easy. You don't have different, channels of distribution. And we've also made coverage options pretty standard. Even in addition to our standard plans, we don't allow benefit substitutions, which makes it easier to design products. And everything really is in one place, full price transparency and even, I would say, even level competition. So we invite any insurer who'd like to come into the individual market to do so. And we work very closely with Commissioner Woods at DSB. They would have to authorize the insurer to do business in the individual market. But I know that is something that she and her team are also very interested in seeing companies come in if they would like to.
Okay. Going from that, in your responses, in your pre-hearing responses to the committee, you stated that residents can now enroll in dental coverage. And before, individuals cannot solely enroll in dental coverage. Why did the exchange make this change? And how many individuals took you up on that offer?
I want to clarify. So before we existed, there was no individual private market for dental coverage. You can only get dental coverage through your job, through your employer benefits. Dental insurance was not sold directly to individuals. So that private market really didn't exist. When we opened for business, we designed our system to enable people who just need dental insurance to enroll. So if they don't need health insurance, they did not have to enroll in health insurance. They can just enroll in dental insurance. And that essentially created a whole private market that didn't exist before. So we have enrollees in just dental insurance who have Medicare or who have job-based coverage, who don't need health insurance through us. And in terms of how many people are enrolled, I can follow up with you with the exact numbers. I think it's about 4,000 residents who have dental insurance through us, and a segment of those just have dental without also having health insurance.
Okay. I feel like this is not your fight. This is more of a federal issue in terms of why we have a situation where, like, to me, dental and vision is very much part of healthcare. And the fact that I have to like go scoop a little from here and a little from here and hope for the best, even though it very much affects your health, right? Like if you get an infection in your mouth, that impacts your entire healthcare. If you get glaucoma, that infects the rest of your healthcare. We don't offer cover for vision. Is that something you're hoping for in the future, or is this having to do with the Affordable Care Act? And again, it's something outside of your control, but you wish that we would change.
Yes, it's definitely on the wish list to change, to clarify the Affordable Care Act, to enable state-based marketplaces and the federal marketplace to also offer vision coverage. So that is a limitation. The Affordable Care Act was not perfect. It was a huge step forward to helping people get insured and stay insured. The hope had always been to come back and make it better, just like we do with Medicare, but fixing the vision limitation has not been done. And I just want to underscore what you said about dental coverage. You remember not too long ago, there was a case where a boy in Maryland died. He had an infection in his tooth. His parents couldn't afford to take him to the dentist. And by the time they took him to the emergency room, it was too late. He died. So what you said about the importance of dental care is absolutely correct in terms of the science and medical evidence. It's just as important as other types of healthcare. And I'm thrilled that we're able to offer dental plans to residents. And we also have dental plans for employers through SHOP as well.
That's great. How are you all providing outreach and communication so that folks know that this is an option that is available to them? Because it comes up more often than not. I think once, people hit their 30s, they're like, oh, I need dental insurance. You don't really think about it in your 20s unless for a variety of reasons. But for most people, they're like, okay, I get my cleanings, every 6 months or so, and we, keep it moving. But I feel like dental coverage of most is the least robust of the health insurance that is offered. So I guess my question is more or less in terms of, are you all doing specific outreach to let DC residents know that this is an option that's available to them, even if they're not seeking full coverage for healthcare?
So one year we did bus ads during open enrollment, specifically focused on dental coverage available through DC Health Link. What we do when you go to dchealthlink.com, there's a anonymous shopping tool we call Plan Match, and it's great because in less than a minute you can figure out what's best for you. And when you click on Plan Match, we ask you, are you looking for dental or health insurance? So we essentially nudge you into the right consumer decision support tool. And then that Plan Match tool, anonymous shopping, helps you figure out what the best dental plan is for you, depending on what you're looking for, if you have particular dentists that you're looking for. So that's a big way we make our residents aware of dental coverage. Now, our DC Health Link certified brokers provide a lot of benefits to the clients they serve, in addition to providing advice on what the best health plan options are. They also typically inform employers of the dental plan options through us directly or outside of us when it comes to group coverage, as well as vision and other benefits some small businesses like disability or life insurance. Another limitation under the ACA statute, we're not able to provide that full benefit package to our customers.
So when you say a limitation, does that preclude the district if we wanted to set up a quote unquote state-run plan for dental? Could we do that?
If I understand your question, so or let me just clarify my answer. As a state-based marketplace, we can only offer certain coverage through the exchange.
Okay.
The district can, whatever outside of us the district wants to do, there may be some standards that apply, but
Right.
it's not an ACA limitation. We can also look at leveraging our technology, which is open source, cloud-based and agile, and it's just cutting edge IT technology to support any potential new initiative that the district may have in the area of dental. I also want to add that there are great insurance companies that offer dental through us.
Okay, great. It is time for a break. So we will be back in 2 minutes. All right, thank you.
Oh, thank you. All the way here. Thanks. A little bit more. I just wanted.
All right, we are back. We heard a number of public witnesses who testified about healthcare for childcare, which I think is one of the all of the things that you do is great. But this initiative to me, I think is so exciting because it came out of an initiative from the council to create the Early Educator Compensation Equity Fund. And out of the work of that task force, who determined that salaries alone were just not enough if we can offer benefits as well, or provide an opportunity for these small business owners, as you heard, some of them having as few as 3 employees, to be able to provide this benefit. It can be used as not only a recruitment tool, but also as a retention mechanism as well for them to hold on to their folks. Can you share a little bit about what you have learned as you've rolled out this program to help improve or expand in the future?
Yes. We've learned many things. First of all, when we started on this initiative, immediately after the Budget Support Act was passed, we wanted to make sure that we launched the affordable coverage option for these centers and homes and their workers as quickly as possible. We also wanted to make sure that as many workers as possible benefited. So we didn't, from talking to centers and homes in all 8 wards, from talking to some of the advocates who helped get the fund established and clarified to include benefits, from talking to many folks on the ground representing this community, we learned that the need for affordable coverage was significant. And not only did the teachers and the assistant teachers who qualify for pay equity wage supplement needed affordable coverage, but everyone who supports those teachers. So the cleaners, the cooks, the directors, the administrative staff. So the need was great. So that was our approach. We talked to as many people as possible to understand where the needs were, and based on that, concluded we needed to launch this as quickly as possible to benefit as many people as possible. In operationalizing this program, we also learned that this is a very hard to reach community. It doesn't matter that we've sent, thousands of emails. We've made hundreds of calls, and we also went out in person to try to reach these centers and homes and talk to them about healthcare for childcare. It is just a hard to reach community. And I really appreciate what one of the witnesses said earlier, Jeff Credit. I think he made the observation that there are still people who don't know about healthcare for childcare. So that's a challenge. Now, there's still people who don't know about the Affordable Care Act after all these years. So we know we won't reach 100%, but that is certainly our goal. And that was part of the reason we established the advisory council, to not only help us with policy questions and provide us with input so we can make decisions that actually work for this community, but also to help be trusted voices in the community to help us spread the message and talk about the merits of this program and how it can benefit a home, an extended home, or expanded home, or a center.
I want to drill down a little bit on some of the data that you provided. Of the 61 employers offering the free or reduced premiums, how did it shake out in terms of who selected what plan option?
I will have to follow up with you on who enrolled in silver, how many enrollees we have in silver level, gold, and platinum.
Okay.
I'll get you that data point. But I have additional information on our February 1st groups as well.
Oh, yes, that'd be great.
Okay. For February 1st, we have 10 new employers enrolled. So that with the January groups, that is 111 licensed facilities out of 394 licensed facilities. So we're at about 25% penetration rate. That does not include about 75 facilities with more than 100 employees, because currently there's only partial eligibility for those.
Right.
And out of the folks who are enrolled, we have close to 200 DC residents out of 790 who are eligible. So that's about 20% so far. Of course, our goal is 100%, but this I think is a good indication of our how we're prioritizing this the Healthcare for Childcare initiative with our resources, with staffing, and working with the community impacted.
How is the relationship in terms of working with OSSI to be able to, because I'm sure, If the assistant superintendent for early learning calls a center, they're going to take her call. If you all call, they might be like, who are you and what do you want with us as we're trying to provide care to children? So I think for us to launch this program and roll it out, having 111 centers is certainly an achievement. I would love to see more. And so I want to understand what your plan is in terms of penetrating and how you're going to partner with some of our other agencies to make sure that folks are getting the word out in the same way that it took us a while for folks to know that we were giving out that available to them, was a $14,000 supplemental payment. It took getting a couple of people to actually receive their check that people were like, oh, it's real. Hold on. Let me go fill out the paperwork. And so I imagine something like this is similar. It's going to be a certain level of word of mouth, but I want to make sure that we're doing everything on our end to penetrate as much as possible.
Thank you. So OSSI has been an incredible partner. We have a data sharing agreement. They've shared data with us under that agreement. We know exactly the DC residents who qualify. We know the OSSI licensed centers and homes who qualify. OSSI has sent emails to folks. We've asked them to send emails to DC residents and homes that qualify. OSSI also invited us to participate in some of their stakeholder webinars and calls. And they've provided input and advice and introductions to associations and leaders in this community for us. So they've been an incredible partner to help us, and they continue to be. In terms of our effort and outreach, so we'll be asking you for help and we'll be asking all council members for help to help spread the word. We are using testimonials from employers and workers who've enrolled as part of our pamphlets and literature. We continue to focus our efforts on the strategies that have worked to date, which is a gazillion emails until people get tired of hearing from us, in-person visits, and telephone calls are very effective for us. We do virtual appointments, we do in-person appointments, we go on site to enroll people. We've used all of those strategies. The one strategy we're not using, and it's because we think it's going to lead to a lot of confusion and get to a population we're not trying to get to, is just general advertising. Because this is a very tailored population, we know exactly who qualifies. We decided not to do broad-based, yes, because that will lead to confusion.
Yeah.
And people aren't going to understand why they don't qualify or not be happy about it, and we're just going to overreach. So that's the one thing we're not doing.
Yeah, we did that for the supplemental payments, and there were several people who submitted information who didn't qualify at all. But any person oh, I see the opportunity to do this thing in the, let me just see if I could slide through the cracks type of deal. So I understand why you all are being much more targeted in your outreach to just minimize the headache, frankly, of having to deal with those situations.
And may I add one other challenge? And this goes to your first question also about lessons learned. And we heard it from one of the witnesses. Some employers, some centers are sitting it out now because they're worried that if they start offering, that the funding won't be there long term. And then it presents a huge employee relationship problem. So we have lots of employers we've talked to who are interested, but they're not willing to sign up because of the uncertainty for year two. So that is a challenge to overcome, and it can be overcome once there's certainty about funding.
Yeah, the funding is protected. I think it's a question of, I think in sort of the order of operations, if you will, the salary piece is first, and then the benefits is after that. So that's I think a kink that we'll have to kind of work through that perhaps won't be solidified until OSSI moves to the next stage, which is the pay scale and the funding being provided directly to the centers to be able to provide the salary increase. But definitely heard you on that front. So speaking of sort of the money, you noted in your responses to the committee that 18 million was sent from the Office of the State Superintendent for Education to your agency for the premiums. Can you explain that process? Is it I don't believe it's reimbursement. Is it just an upfront cost, and then what you don't spend down, what happens?
So we either have an MOU or an MOA. I'll follow up on exactly what we have with OSSI. And the 18 million is in a separate bank account for the sole purpose of paying health insurance premiums. That's it. Not a dollar of it goes anywhere else.
Okay.
And it's a completely, segregated bank account from all of our operational expenses and everything else. So because there's a guarantee of free or lower premiums for 2023, that crosses over fiscal years.
Right.
And so the agreement we have with OSSI is that it just the funding sits there until it is exhausted for 2023 premiums. One of the things I forgot to also mention earlier, another challenge that we faced is we weren't sure how far 18 million would stretch. And when we're working on this, it was before we had rates for 2020, premium rates for 2023.
Right.
We weren't sure about take-up rate. And so we thought, well, let's start with paying for silver level. The advantage to standard plans is you get lots of essential care without deductibles, but the downside is that the deductibles for silver are higher than this population can afford, which is a barrier to medical care. So we're looking at, and in a few months, we'll have a better sense, but we're also looking at whether or not in future years, should this program continue, and that's the hope, of course, if we can, if the funding is enough to pay for gold level, because that eliminates a huge barrier to care, which is the deductible.
So how much have you spent down already?
Not a whole lot. For January groups, I think it was like 225,000.
Oh, really?
Yes.
Okay. So in terms of the 18 million, you feel like that is more than enough to carry you through the agreement of this year?
Yes.
Okay, great. All right. Let's start talking a little bit about some of the health equity work. You touched on this a little bit in your testimony, but can you explain again the purpose of You touched on this a little bit in your testimony about the disparities in terms of COVID. And I'll just mention it again. Black Americans who contracted COVID are dying at 1.8 times the rate of white Americans. Latinos 1.3, American, Indian, or Alaskan Natives 1.4 times the rate. I feel like there's a bit of mismessaging that's happening, I think, for some folks, right? You hear the news, we started talking about, oh, the president is winding down the public health emergency, and yet we still know that individuals are very much dying from contracting COVID. How are you all working to, I guess I'm curious, what is your approach in terms of your messaging as it pertains to COVID under the health equity space?
Mm-hmm. So we're relying on DC Health essentially from day one for all messaging around public health and COVID. So we do not have our own messaging around COVID. But in terms of how we can help, and the problem you're raising is a health equity problem. There is no health equity, and that's why there's a disproportionate impact of COVID on communities of color. Now, we've learned many things through the board's social justice and health disparities working group, in that all of this is systemic racism, but it's complicated because it could be financial barriers to getting the care you need that leads to more deaths, more hospitalizations, for example, with COVID. But we also know there's significant bias. And so you could be the wealthiest Black woman in DC and still suffer discrimination when you are in the healthcare system. And I sometimes like to call it the Beyonce problem or the Serena Williams problem. You can still die during pregnancy if you're Black. So it's not merely a financial problem, although financial barriers are a major problem to getting better outcomes across the board. It's also a bias. It's also clinical guidelines. In fact, one of our health plans helped us understand this. And there's a great article out there by Harvard researchers and other researchers that identifies specific clinical guidelines that actually have a race adjustment. And when that race adjustment is applied, if you're Black, you just get a worse outcome. And I'll give you an example. Kidney function test, GFR, used to have, and it's been changed in the last couple of years, the clinical guidelines, but it used to adjust your score for how well your kidneys work based on your race. So if you got the test and you're Black, the test showed that your kidneys functioned better than they actually did because there was an upward adjustment to your score. And that meant there was a delay in getting you the care you needed, maybe a delay in getting a transplant. So that's just one of many examples where there are actually clinical guidelines that perpetuate or exaggerate the differences in health outcomes. So in terms of our role, we are trying to tackle this for the population covered by us through group or individual coverage in a very strategic and segmented way, because each of these factors lead to bad outcomes and differences in outcomes depending on race and ethnicity and other characteristics. And so we are trying to tackle it from different ways.
In the documents that you've submitted to the committee in terms of the enrollment levels by ward, Ward 7 and 8 have the lowest number enrolled in DC HealthLink. I think I might understand why that might be, but I do want to ask for the record. I'm guessing that's because there's a larger share of individuals who are probably covered through Medicaid or Medicare and therefore don't get their insurance through the HealthLink, but I want to ask on the record.
Yes, that's correct. But in addition, some wards do have higher uninsured rates, even though there's a high penetration of public insurance enrollment. And so we do focus many resources on wards with higher uninsured rates. And we have specific targeted outreach programs in those wards.
Okay. How do you measure quality in terms of the products that you all are putting into the market?
Well, they're all Affordable Care Act, health insurance, and I'll just give you an example.
Well, let me ask it a little bit differently. I guess, how do you measure quality in terms of how residents and business owners interact with your agency?
Oh, okay. So we're not perfect. We are always looking to be better and learn and improve. And so I don't measure our success by perfection. That's impossible. I measure our success by how responsive we are and how quickly we can solve problems and ultimately how quickly we can make sure if you want coverage, you get enrolled. And if you want to keep your coverage, we help you stay enrolled. And that's kind of the ultimate test for us. But I do want to say something about the quality of the Affordable Care Act health insurance. You know, before the ACA, anything could be called health insurance. And you didn't know whether it worked or not until you got really sick. And then you found out you bought a junk plan that didn't work for you, or had an annual limit of $100,000 that didn't even pay for a hospital stay. You know, the miracle of the Affordable Care Act is that it sets standards for what health insurance needs to be and how it needs to work. Now, is it perfect? No. I talked about the higher deductibles at some levels. We don't like that either. So we hope over the years, Congress will and the federal administration will come up with approaches to help people not only with premiums, but also with actually accessing care and doing something about the higher deductibles.
Okay. Let's talk about the call center. Do you have an idea of what the average wait time was for incoming calls in FY22?
Much better than in our prior years. So I want to say about 5 minutes, maybe even less, but I'll get you the exact data point. And so I just want to say something about contact centers. In our early years, we sometimes had, 2-3 hour wait times. And we're not unique. That was the case for healthcare.gov and the other states as well. And over the years, we've spent a lot of resources working with our vendor partner to improve the quality of the calls, the first call resolution, as well as the wait times. Last year, we've done better than in prior years, and every year we look to improve.
Okay. As I understand it, you all are continuing to operate in a hybrid status with some of your employees fully remote and others partially teleworking. This includes your call center remaining fully remote as well. How is that working for you all, particularly for the call center piece? From a quality control standpoint, are you all satisfied with your vendor and even with the 100% remote posture, or do you feel like at this particular stage you might need to make a change?
Oh, it's been great. Going virtual, I wish we did that earlier, frankly, for the call center. What we find, and this was advice from the vendor our vendor did a pilot with Maryland. They also support Maryland's exchange, or at the time they did. And so they did a pilot and they found that having partially virtual staff helped with retention. And this is all before COVID. And so there was good experience there doing remote. And so once COVID hit, within 2 weeks, we actually took our physical call center and converted it into virtual, supplying workers with the equipment they needed to take calls virtually. And it's really been great. And I would say has contributed to retention of quality workers for the vendor. It gives people more flexibility. They also don't have the expense of commuting. And call center jobs are not the highest paying jobs. And so a commute that adds extra financial burden is a problem for recruitment purposes. So it's really been helpful. And of course, when you can retain call center staff, they just know more. They are experts and they can provide better advice and help to folks calling in. So it's not a learning curve over and over again. The quality of the calls are very good, and we have a significant quality assurance monitoring program. In the early years, every week I used to get together with the vendor and their staff and listen to the calls and give them feedback on answering questions correctly. My team and I did that. I don't do that anymore, but my team still does on a weekly basis. So it's been really, the quality has improved tremendously over the years as well.
No, I mean, that's what we want to hear in terms of from a performance standpoint, because I do remember in those early days, it was rough. And so now, obviously, during open enrollment, I'm sure there's a peak in terms of the number of calls that you're receiving. And so wait times are probably longer, but it is good to hear that not only are the wait times down, but also that you have been able to resolve some of the retention issues with your representatives there.
And we've saved on rent.
Oh, have you really, like, have you did not renew the lease for that particular space?
Correct. So that's a big savings in our budget as well.
Okay. What about your permanent location for the staff outside of the call center?
So DGS represents us in renegotiating the lease. Our lease expires in the next year or so.
Okay.
And so DGS is renegotiating.
So you are going to maintain HBX as an agency is going to maintain a physical space, even though you have folks who are doing multiple things.
Yes, we are reducing. Right now we have reducing our physical space. So right now we have space on 2 floors.
Mhm.
We're just going to combine it all onto 1 floor, essentially. That's what we're looking at, especially with hybrid work environments. We're looking more at kind of hoteling. So when you're in the office, you may have a different office each time you come in. Or
Reserve a
different
conference space in a very
cubicles. Yeah.
I know
and
my
that's what
other
this-
hat and sort of thinking about how this impacts our commercial real estate market doesn't like to hear the idea that you are going to be reducing the rental space, but I do understand that it makes sense. How many employees total do you all have right now?
We're authorized for 120 FTEs, and we have 12 vacancies right now. We're hiring.
That's what I was going to ask. Are those positions posted?
Yes, we use the DC system of posting.
It's on DCHR.
Whatever system DCHR uses, we post there. We also use, the internet websites, the recruitment websites to post as well.
Okay.
And I'll get you the actual names of those sites. I just don't remember all of them.
Okay, give me just a second. Okay, I'm just going to check with Ashley to see any of my colleagues in the attendee room or chat that I might have missed. All right, well, I don't have any further questions right here at this time. We may submit some follow-ups to get some of the data points that you said that you would follow up with us on. Give me a second. So we will follow up with your team on those specific things, but I want to thank you so much for your testimony and for coming in today. Like I said, we'll follow up on the other additional pieces. I will say again, for the public witnesses who were unable to testify in person or speak at today's hearing, we will accept public witness testimony until February 15th at 5 p.m. You may submit written statements to Ashley Strange at astrange@dccouncil.gov, or you may leave a voicemail at 202-430-6046. If you leave a voicemail, please remember to speak slowly and to spell your name for the record. These are the joys of one of the things that we have done since COVID, and I think a lot of residents have taken advantage of it. This concludes today's performance oversight hearing for the Health Benefit Exchange. Our next hearing will be for public witnesses providing testimony for the Department of Behavioral Health, and that will start at 2 o'clock this afternoon. So thank you, Mila, and your team. The time is 12:33 in, I guess, do I say recessed or adjourned? Okay, great. There's a new link. So this hearing is adjourned, and we will see you at budget oversight. Thank you.